So my regards to chairpersons, and I will be dealing with silent feto-maternal hemorrhage and RH negative Dr. Deepika Deka. I'm really grateful, and how we learn from small things that she had such a pain, and yet she was so concerned that yes, this panel to be done, how it will be done, you can do it, and she is able to make it. So these are the small things which tells a volume about a person's character. And I will say at this moment, Dr. Deepika, though the Northeast is really fully with me, but I want your word about me in the Northeast also. So you have a great following over there, so that will be endorsing my support. So thank you. It's all about like staying together. Just on 18 June, we have a wonderful program in this hall only. That was the first annual academia meet for the North India Gynae Forum, and what Dr. Sharda Jain and everybody says, we look forward to great future ahead. So Gorakhpur is known for many things now. It is for Gita Press, it is for Gorakhnath Mandir, it is for Buddhas, and it is for CM Yogi Adityanath, who is again something very strong and exemplary person in politics. Buddha says we can never obtain peace in the outer world until we make peace with ourselves. So maybe it is any clinical tough situation, maybe it is fighting a very tough election, it is the same that we have to be very peaceful at the core of our heart. So just to the August gathering, I will put on the few important things. So when actually we didn't have that technology and the many things what we have today, but the human wisdom was always same. It is always the human wisdom. So it is a very like sharp observation of Williams in 1903 that we find this dropsy fetus who is 4 to 5 times larger size than the normal baby, and actually we don't know why it is happening. So when we see the flashback of the history of medicine, what we say, the Buddha says that existence is sorrow. And why there is sorrow? Because God wants to like bring out our compassion, so that the sorrow troubles us and we want to good for the people. And it is all about the origin of science and the arts. So when we got this cause analysis, when Carl Leinster and Levin actually found out that there is one RH factor which is found in RH rhesus monkey, and now I wish to say that the RH word is not used, it is a D, because it is now considered misnomer. Then the Levin discovered RH antibody, and in 1944 that puzzle was solved when we have all C, C, D, D, E, E classification. So the technical point I will be leaving in the presentation, because Dr. Deepika Deka will be doing the best job for it. Then what is the compassion of the people? That is something very interesting, that Baumann and Chown found the Winnipeg RH Institute. And that was in Canada, and they used to collect the antibodies from the RH negative mother who had the RH positive pregnancy. And that was a 1/3 cost for the Rogam what we had from the Johnson and Johnson. And that was that pure that it could be given even IV. So it was something human effort. And just what I say, that it is like people make money, but we can make money by many means. But how we make money, actually that is very important, because when we are doing something very good, you are serving people, you are giving a very quality thing, quality consultation at a reasonable cost, and that actually costs. So this is the from tragedy to triumph. It is the, and what is the all world is independent doctor, recipient, giver and taker, and from general practitioner to obstetrician to the fetal medicine expert, which we are together. Despite that we have a lot of technology, the important thing that we are having more and more, like not less RH isoimmunization, because of many things we will be discussing in panel. The one very important point is the missing NTD, and the second is very rampant use of medical abortion drug without having any RH testing, and the people are having in like many times they are taking the medical abortion drug. So it is a global failure. It is not only in our country, it is the global failure, and we have to prevent the preventable. So we know a lot of blood group. It is not only NTD, the 33 different blood group, 339 red cell antigen, and all CC, DDE. Just I wish to say that the C and E also can cause the hemolytic disease of newborn. maybe of the less severity, sometime more, and the D is the only one. So when we are only focusing on the on the D group, sometime we may face the certain uncertain situation why the baby is having that neonatal hemolytic disease, because we have to look into that CCED. We are fortunate that we are having 6 to 7% Rh negative, but in absolute number it is quite high because we are 1.4 billion. So we have the Rh negative incidence lesser than the American or the Western world. So this is the important thing. And when I attended this WHO, my third meeting as a FOXY representative in Colombo, that was the first time that the WHO focused on the prevention of stillbirth, which is considered a silent tragedy, because the fetus and the newborn are getting like in utero death, and that is the essential newborn action plan. And now it is our government plan that we have the essential newborn action plan, and the antibody and the fetal-maternal hemorrhage is standard, and the NTD, like Rh negative pregnancy, is one of the main contributor where we can prevent the stillbirth, the fetal and the newborn criticality. So this was a very fond picture. And I always, what we say, I got 3 times opportunity to attend WHO. Now, it is one for my merit also, but it is for because I could have that group-like feeling. I was always a part of team, learning from all countries, and you have to have the 4 or 5 days meeting. So it is something wonderful to know about world. So coming to silent fetal-maternal hemorrhage, that it can cause, it is an antepartum or postpartum entrance of fetal blood. So fetus and mother, they are like close, they are वो लोग सबसे ज़्यादा पड़ोसी हैं. So it can be non-significant. The fetal blood is going to pass through the intravillous space into the maternal blood circulation, and whenever there is any issue about the antigenicity, mother will have antibody and cause the fetal hemolytic disease. So it can be from non-significant to catastrophic neonatal outcome, which we will just share a few case situation, and clinically insignificant. It is ongoing thing that a little bit of fetal-maternal hemorrhage and the fetal blood is getting transmitted to the maternal blood. But we can have clinically significant fetal-maternal hemorrhage that is more than 30 ml in around 3 per 1,000. So it is not that less. 3 per 1,000 is quite a good number, and we have to be like really thinking for fetal-maternal hemorrhage when we have a certain uncertain clinical situation, when we are not going to have actually what was the cause. So up to less than 15 ml, that is 0.025 in 75%. So a small amount of fetal blood is always there in maternal circulation, but it is usually less than 15 ml in 99% of the women, and it is 30 ml, and when it is around 80 ml, we say that it is a massive fetal-maternal hemorrhage. It can be spontaneous and it can be traumatic. So traumatic, we have to be a thing which is something, a new thing, because our women are exposed to so many professional, everybody is driving scooties, they are traveling 30-40 kilometers to like teach, to have a small job, and the trauma is something which is very important cause of the fetal-maternal hemorrhage. It can be acute fetal-maternal hemorrhage when there is a sudden rapid fetal blood loss, perinatal hypoxia, sudden unexplained death, which is actually a sore thing to deal with in today's obstetrical practice. And sometimes the baby is flat with the severe anemia and hypoxia. You did cesarean section for a non-reassuring fetal pattern, and you find suddenly flat baby. So it is a sad thing for family, for doctor, and potential medico-legal issues as well. Chronic fetal-maternal hemorrhage, it is intermittent or recurrent fetal blood loss, and always when we are having to something chronic, we are adapted to. We have less money, we are adapted to get that, doing our things in that. So there is a compensatory increase in the hemopoietic activity of the fetus, and still if there is inadequate compensatory mechanism, you can have the high drops. So always fetal-maternal hemorrhage, we know as a obstetrician that less in first trimester and maximum in the third trimester. So it is a common phenomena, but when it is a moderate to massive, then it can cause any unexplained fetal anemia, fetal high drops, and fetal stillbirth. So the massive FMH is around 1 in 1,000, so it is also not less. Cause can be the traumatic, what I say, all women, our even rural women, जिसमें आप कभी सोचते भी नहीं है कि like sometime हम लोगों को लगता है अच्छा ये वर्क नहीं करते होंगे, और बिल्कुल जो रूरल और मिड वेरी लो सोशल कम्युनिटी जैसे नहीं, हम आंगनवाड़ी में काम करते हैं, हम ये आशा का काम करते हैं, they had a very tough life and now we have to be very like taking history of the like minor accident or something. Then placenta previa, abruptia, tumor, umbilical vein thrombosis, all hypertensive disorders, substance abuse, and every invasive procedure, which is we are offering so much because of our knowledge on the fetal medicine, can have the potential to have the fetal maternal hemorrhage. So it is a trauma, and it is not only motor vehicle, intimate part violence, homicide, ground, this thing, what is the violence, and obstetrical, all procedure, ECV, chordocentesis, amniocentesis, and the placental pathology, and of course vasa previa. Maternal characteristic, race, ethnicity, everything we have to consider. Fetal characteristics important, fetal anomalies, malformation. Twin to twin transfusion is important cause for the feto-maternal hemorrhage. And what we say, placental abruptio can cause definitely umbilical vein thrombosis, anomalies, chorioamnitis. Again, a very, very common thing what we see, and the placental tumor. So what the complication, all these things like, so I'm just, so pathophysiology, it is not actually clear, but important thing is that there is a breach in the placental trophoblastic barrier, so fetal blood cell move away from higher pressure to the lower pressure and ultimately into maternal circulation, and many things can happen at etiopathogenesis, intervillous thrombosis, villus edema, villus dysmajority. So this can be there, but it is the clinical activity which we have to be very like sensitive about it. Majority may be asymptomatic because everything is gone. It is a small amount, and diagnostic technique is expensive, and precise volume of feto-maternal hemorrhage is difficult. So this is all about the and how they can present. So one thing I will say very, very important, the decreased fetal movement, which every time the patient says, और कई बार लोग इतना जल्दी आते हैं कि हमको लगता है कि पता नहीं, like they are something psychological and not looking into it. But the first like sign of the feto-maternal hemorrhage can be decreased fetal heart rate, decreased fetal movement, then sinusoidal heart rate pattern, and uterine tenderness or vaginal bleeding. So uterine tenderness or hypertonus is something which we have to be always clear. Unexplained stillbirth, unexplained elevated middle cerebral artery Doppler, and the early neonatal anemia. So these are the things which can present as a clinical presentation in the feto-maternal hemorrhage, and always when trauma you have to look into it. What is the diagnostic modality? So quantification I will just say, क्योंकि I will talk about it because what I have noted in all pan-India programs, that when we say कि किसी भी institution में Klehor-Bat के test होता है या flow cytometry होती है, they always say नहीं होता. So it is something that like with all the like a very expertise that it is not that costly test, it is not that thing, but it is not available in most of the clinical setting, and that's why we have inadequate NTD also, because we are not doing the quantification. Fetal testing may include CTG, obstetrical ultrasound, fetal hemoglobin if we do by the MCV, MCA, PSV, or the chordocentesis, biophysical profile, and initial laboratory assessment, blood count, urinalysis, metabolic profile, blood typing, and the all RH. So it is Rosette test. I am not going into detail because Rosette test is the point of care test. आप उसको immediately मिलता है, and the fetal cell is rise rose, and what the Western world have, it is a point of care. अगर Rosette test में आपको fetal blood cell दिखते हैं, then they go for the full-fledged Klehor-Batke test and the flow cytometry, which is not available. So important thing is not about knowing the details. Important thing is that how this test is not that easily available for our practitioner, and sometime even in institution. So I'm not going into detail, but it is a little matter of concern, because if we are not doing the quantification, we might be having many problems, including the less dose of NTD antibody. So I will say that we will have, अगर किसी को difficult delivery है, PPH हुआ, it is always better that we either do Klehor-Batke test or we add on the 100 microgram of NTD with the conventional 300 IU dose. So these are the method where I feel that it is a gap, because everybody says that it is not available in most of my programs. CTG साइनोसाइडल पैटर्न जहाँ एक्सेलरेशन डिसेलरेशन नहीं होता. Important thing मैंने इसमें दो इमेज दी हैं. The first is the pseudo-sinusoidal. So it is a small, but the fetus is having acceleration and deceleration. But that is the simple. So sinusoidal pattern is the pathognomic of the feto-maternal hemorrhage, and the biophysical profile, though biophysical profile has not get that strong correlation. Fetal anemia we will have in the panel MCA, PSV, and it is a non-invasive method, and it is just, I will wish to say that we need the person like Dr. Deepika Deka, that it is not that every ultrasonologist can do a right MCA, PSV assessment. Good section, good setting of the Doppler tone, and the good statistical analysis. That is the thing. So if, as a obstetrician, if we think that it is something really wrong, it is better that it is the time to refer to the best person in the city. Fetal hemoglobin level, we can do chordocentesis. I think Dr. Deepika will agree. If you are doing chordocentesis, at the same time you must have the facility for intrauterine transfusion if the baby found to be anemic. So this is important, and you can have many ultrasound signs of the hydrops, hepatomegaly, splenomegaly, placental thickness. Important thing is no parameter is sensitive enough to be used as an independent marker of the fetal anemia. So this is very important, and if there is no hydrops, no ultrasound finding can distinguish mild from severe disease. So MCA PSV is the thing which is with us, which is going to stay, but it should be well done to remove, like assess the intra-observer and all variation. So CTG, biophysical profile, MCA, and then the quantification test. What we can have, RH isomination, hemolytic disease of newborn, fetal death, and a lot of neonatal complication, जो कि हम लोगों के जो केस होते हैं वो ये होता है कि 1 महीने बाद ये हुआ, 3 महीने बाद हुआ, हम आपको इतना दिखा रहे थे, आपने इतना अल्ट्रासाउंड किया, and we will just discuss in last 1 or 2 cases which they have provided that how the patient, neonate can come with the unexplained respiratory distress, metabolic acidosis, brain ischemia, renal disorder, and the liver damage. So how we manage about it, it is less than 32-week fetal maternal hemorrhage, more than 20 ml, immediate cesarean section is recommended for neonatal transfusion. Less than 32-week severe FMH, intravascular, that is intrauterine transfusion, more than 23-week corticosteroid, Maxel for neuroprotection, and then planned delivery as per the IUT or the delivery. So this is the thing, and NTD, which we will be discussing in panel, that what is the dose. So I am just omitting because we will be discussing in the panel. Steroid, a little bit, it is not more than 34-35 week, with lots of the few recommendations says that it might be associated with something cognitive impairment in the newborn, like a baby's life, but actually we are little skeptical. We will have to have opinion of chairs also, that actually the still many societies says that if we give at 36-37 week steroid, then it reduces the respiratory morbidity and the transient tachypnea of newborn. So if you give it, it must be the informed consent. So it is something gray area which I am not going. Intrauterine transfusion, I think Dr. Deepika Deka will be dealing, so I am not at all going into it because she is there, and how to monitor. And this is the study from like Dr. Deka, that Val is the part of it, that what they have the PRM cord hematoma after intrauterine transfusion. So it is one study with Dr. Deka must be happy to see that I have included it, and this is our experience in India, and this is the study which is in Nauroji Bhatia Hospital. So that is the reason for low survival rate. That is a little older paper which shows, again I will say, the gaps in our system, late referral, severe RH illumination, non-availability of blood causing delay in intrauterine transfusion, use of non-radiated blood, and volume overload. So these are few things which we have to say. So IUT, I am not going to it. NTD we will be discussing into the panel. So that is, I am not opening the answer to a panel. So important thing is that we miss MTD administration, and why it is sometime in emergency, आपने कर दिया, सब कुछ हो गया, तीसरे दिन मालूम पड़ा अच्छा उसका ब्लड ग्रुप तो पॉजिटिव था. एंड वी मस्ट हैव दैट. आई थिंक हर केस शीट और एंटीनेटल कार्ड पे ब्लड ग्रुप RH टाइपिंग का ब्लॉक होना चाहिए, सो दैट कोई मिस नहीं करता. सबसे पहले उसका ये ध्यान रहे कि ब्लड ग्रुप है या नहीं. अगर हमारे पास ब्लॉक नहीं होगा, वी टेंड टू गेट मिसिंग लाइक समटाइम इन so many things. Error in typing mother or infant blood, unrecognized feto-maternal hemorrhage, or inadequate RH IgG dose because we are not doing the Klehor-Batke or the quantitative estimation. So I am not going to do so. I will just say anti-D I am not covering. A little bit about the BSV what polyclonal जो विनीपेग इंस्टीट्यूट था, फिर रोगैम आया और अब ये मोनोक्लोनल रिकॉम्बिटेंट टेक्नोलॉजी. सो इट इज़ फॉर BSV's ग्रेट एफर्ट. सबको याद होगा जो लोग पुराने 86 में जब अचानक HIV आया और सारे ब्लड प्रोडक्ट पे एकदम इतना लाइक समथिंग गॉन ऑन, और सारे गोनाडोट्रोपिन्स और सारी वैक्सीन्स पे चीज़ आई. ब्लड बैंक के बहुत स्ट्रिक्ट प्रोटोकॉल उसके बाद शुरू हुए. सो इट इज़ अ लॉट ऑफ इशू विद ह्यूमन प्रोडक्ट. सो नाउ वी हैव द रिकॉम्बिटेंट टेक्नोलॉजी. सो एडवांटेज आर स्पेसिफिक, कंसिस्टेंट, यूनिफॉर्म, सेफ फ्रॉम ट्रांसमिशन ऑफ वायरस एंड हार्मफुल टेक्नोलॉजी जो हम लोग गोनाडोट्रोपिन्स में भी कर रहे हैं. बिकॉज एवरी टाइम हम लोगों को अब ह्यूमन रिसोर्सेज नहीं मिल रहा है, सो हम लोग नॉन ह्यूमन रिसोर्सेज पे जा रहे हैं. सो इट इज़ मोनोक्लोनल पॉलीक्लोनल. सो मोनोक्लोनल ग्रेटर एंड कॉन्सिस्टेंस, हाई स्पेसिफिसिटी, हाफ लाइफ इज 23 days एज कम्पेयर टू 15 days, highly purified, high homogeneity, no risk of transmission, and unlimited supply. So this is the monoclonal which unfortunately is there, क्योंकि एंटी-डी जैसे वैक्सीन जैसे ये गायब हो जाती है मार्केट से, देन चाहे हमको कोई भी नॉलेज हो, वी आर नॉट गोइंग टू हैव एनीथिंग. सो वी हैव टू हैव ए वेरी रिस्पेक्टफुल, म्यूचुअल रिस्पेक्टफुल रिलेशनशिप विद द इंडस्ट्री पीपल, एंड दिस इज द फॉक्सी गाइडलाइन विच आई एम नॉट डूइंग बिकॉज इट इज़ एंटी-डी. वी आर गोइंग टू हैव द पैनल. नियोनेटल मैनेजमेंट, ऑलवेज फीटो मैटरनल हैमरेज, ये सबका रहता है. कभी कभी हमको अनएक्सप्लेन्ड पेल बच्चा मिलता है, अनएक्सप्लेन्ड फीटल नियोनेटल शॉक मिलता है, और हमको समझाना बहुत मुश्किल होता है कि क्या करें. सो वी मस्ट हैव ए वेरी वेरी गुड नियोनेटल बैकअप, and this is the thing what it is a complicated thing, important thing. I'm not going, but it is something must we have the neonatal backup. So IV immunoglobulin we will be discussing into the panel. And one thing, have you experienced hydrops neonatal jaundice in RH positive or RH negative women with weak antibody titer? How it puzzled you, what can we do? So there can be the immunization can occur due to other RH antigen. You have the same monitoring device. अगर हमारा दूसरा भी है, same MCA PSV and the intrauterine transfusion and grandmother effect, which the RH positive mother can have the all RH immunization because she has inherited that antibodies from the grandmother. So these are case studies which actually says कि बच्चा बहुत ज़्यादा sick निकला, 2 ग्राम हीमोग्लोबिन, 3 ग्राम हीमोग्लोबिन, excessive fluid blood component, correction of metabolic acidosis, that few babies could be survived and few babies could not be. So finally, most of the fetal maternal hemorrhage remain asymptomatic, underreported. Mild is very common, but massive, moderate to massive is around 1 to 1,000. We have to be more careful in when the woman is RH negative, and we have to be like clinical history, biophysical profile, CTG, and the quantification of this feto-maternal hemorrhage is something which we will look actually into it across the discussion with the pathologist of ours, and we need much more research to need new intervention and improve on existing information. So finally, when we are going to have a wonderful panel with Dr. Deepika Deka, this is the challenge which this paper says that 50% of women around the world who require anti-D immunization do not receive up. And what are the reasons? Lack of awareness, availability, and affordability. And we are having thousands of fetus and neonatal risk for RH disease each year. So this is the book, Final Diagnosis. हो सकता है बहुत लोगों ने किताब पढ़ी हो, मैंने इसको सेकेंड ईयर MBBS में पढ़ा था, और इसमें 2 स्टोरी साथ चलती हैं. वन इज़ द गर्लफ्रेंड बॉयफ्रेंड, तो लाइक ही जस्ट स्लैप ऑन द नी, तो वो कहता है पेन होता है, एंड इट केम आउट टू बी ऑस्टियोक्लास्टोमा. एंड वन मदर हु इज़ कमिंग टू हॉस्पिटल, दिस इज़ ए हॉस्पिटल स्टोरी, कमिंग टू हॉस्पिटल विद एडवर्स आउटकम विद द RH negative disease, and pathologists, and they are having, and that baby also had the fetal death. And when the pathologist actually review the things, what अभी मैडम कह रही थी इतना ईजी हो गया अभी नॉलेज को अपग्रेड करना. सो व्हेन ही रिव्यूड द थिंग, इनडायरेक्ट कोम टेस्ट उन्होंने नहीं कराया था, And pathologist was so upset because it was there in the world and they could access to that ICT test to that mother. और उसमें जो what his teacher says to us, says to that pathologist कि एक समय आएगा आपके पास इतने पेशेंट होंगे कि आपके पास इतनी रिस्पॉन्सिबिलिटी होंगी एडमिनिस्ट्रेटिव कि आपको कुछ पढ़ने के लिए वक्त नहीं मिलेगा, पर आपको कुछ भी हो, आप दुनिया से बिल्कुल अलग हो जाइए, यू क्लोज योर रूम, यू पुट द बैक टू द वर्ल्ड, बट यू हैव टू स्टडी, बिकॉज हमारी रिस्पॉन्सिबिलिटी है कि हम अपने पेशेंट को बेस्ट केयर दें जो इस समय दुनिया में अवेलेबल है. एंड दैट एज ए सेकेंड ईयर स्टूडेंट दैट क्लिक, अभी तक मैं उस चीज़ को कभी भूल नहीं पाए, वेदर आई एम इन हॉलीडे और आई एम गोइंग टू हॉस्पिटल. इट इज़ कभी ऐसा नहीं हुआ कि मैं आधा एक घंटा हम पढ़ के नहीं जाए. ऐसा लगता है, मुझे अभी भी लगता है कि जैसे हम जंग में जा रहे हैं लेकिन हमारे पास अपने हथियार और बंदूक नहीं है. सो दिस इज़ समथिंग टू लाइक व्हाट वी हैव एंड व्हाट वी से. बकुल इज़ विद अस. हम लोग बहुत ज़्यादा पढ़ते थे, शेरो शायरियाँ, कविता, हर चीज़, एंड शी इंट्रोड्यूस मी टू मैनी बुक्स. So finally they say the world has become too complex for simple answers. They are wrong. Leadership is all commitment and conviction, and I again appeal that everyone vote for my forthcoming election. Thank you very much for patient listening.